Hello, let's get started. Today we're going to talk about EMS systems. Hopefully this falls in line with what you and your instructors are working. It does fall in line with the EMT class that I am currently teaching. So let's get started. I will share my screen. In a perfect day, in a perfect world, that's what happens. Okay, so EMT requirements here. So we must meet mental and physical criteria to be capable of performing as an EMT. They do this for the physical side of things. They do this with physical agility testing to make sure you can pick bags up and carry 200-pound patients and all the equipment we need that we can get to the patient side. We have to comply with other state and local employer provisions. So perhaps you have specific protocols that your agency does, or a specific type of patient demographic that you take care of. You may have to comply with the protocols that are set forth for those agencies. And we have the ADA. Within reason, we have to comply with an EMS agency complies with that guarantees a disabled individual's access to state and local government programs. It prohibits the employer from failing to provide full and equal employment for the disabled. So that does fall under EMS to a point. But obviously, if you can't do the physical side and the knowledge side of this job, you do have limitations to that. So talking about the history EMS has been around for a long time before it was called EMS. Ambulances started to become a thing back during World War I, and when volunteers manned the specific ambulances to remove soldiers and injured from battlefields. This became field care in World War II, and field medic and with rapid helicopter evacuation started to occur during the Korean conflict. That's, if you've ever seen the show MASH, that was a very, very good depiction of that. And a good show. So overview of the EMS system. Where did we come from? So back in 1966, the publication of Accidental Death and Disability, the neglected disease of a modern society, was published. And in that, the DOT published the first EMT training curriculum in the 1970s that kind of led to that. And over the next 4 years, to say, hey, we got to do something about this because people are dying in their homes. We could fix this. Let's train some people. So they said, what are we going to do? Let's find some people to train. Here we are. So when I say pave the way, some of you will recognize these two individuals. This is Johnny Gage and Roy DeSoto. They were the crew of the Firehouse Station 51 and in Squad 51. They were paramedics. They were firefighter paramedics that would respond to scene in their fire apparatus and provide advanced care. This was on during the 70s and really, really opened the public's eyes to what EMS could be. And then from that point, it really did become something. Randolph Mantooth, which is the individual on the right, he's a very good public speaker, and he's made his rounds through the years. So things he said, it really hit home. So what you do has a direct impact on other people's lives. So think about everything you do, whether it's the coffee you bought this morning and the person that served you that coffee's interaction, all the way up to the little old lady's patient, the little old lady that is your patient, and all you had to do is hold her hand and make her comfortable. Something, what you do makes a huge impact on people's lives. So, but to truly care for people, you have to truly care for people. So we can't do our jobs and we can't do it with the compassion we have if we do not care about our fellow humans. So keep that in mind. Very insightful statements that Randolph Mantooth made. Still alive. Don't worry, both of them still are. All right. So does what we do come to play? Who says that, EMTs can put a traction splint on, can ventilate, they can learn all these things? Well, they come from a scope of practice. So on a federal level, the National EMS Scope of Practice model provides the guidelines for EMS skills. And then with that, the education programs come from this basic scope of practice model. On a state level, laws and regulate the EMS provider and operations. And they do that with, like right now, we have what's called collaborative protocols. There's all the counties and regions in New York State have gotten together and says, here's a list of our protocols. Let's implement this. This is what our individuals can do out in the field. So, and then locally, agencies, classes, we all have medical directors. Those medical directors decide the day-to-day limits of EMS personnel. So some agencies may be able to do different things in different agencies depending on the medical director. Some agencies may do a lot of interfacility and a lot of critical transport, so they'll be trained to do that, but they'll have different protocols that they can do, pumps, ventilators, that type of thing. So, but the medical director says yay or nay to that. So when we talk about the scope of practice, you have to take all of these entities and they have to work together and they have to overlap. So like the day-to-day operation has to work well with the state EMS offices and has to work well on a national level. All these things have to integrate together. So they work cohesively to make this hierarchy of national EMS scope of practice. So we work together to get this done. So it's you leave one place, you go to another. It'll be a completely different EMS system. It might be run differently, but when it comes back to the basic of patient care, it's pretty familiar place to place you go. So the BEMS, you may hear this referred to as the Bureau of Emergency Medical Services and Trauma Systems. This is New York State's oversight and governing body when it comes to our legislation and our regulation. This determines our protocols, our training, and this is what we practice and follow. All right, and then continuing on that, public health law allows the EMT to practice. The public health law allows the EMT to practice. Say that one more time. The public health law allows the EMT to practice. So ding, 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 hint, hint, Bob's your uncle. That's an important tidbit to take home with you. So this is governed by Article 30 under the DOH public health law. It provides for certification of all advanced life support, first response services, and ambulance services. That's us. You work on an ambulance, you work first response, you work on a fire or rescue, work falls right into there. All right. So looking at the components of an EMS system, what is the anatomy of an EMS system when you look at that? So you look at the whole system and you look at these components. So the first thing that has to happen is an incident has to be recognized. Once it's recognized, 911 is called, goes to the dispatcher, but also the call taker. So the call taker takes the call, and while they're taking information in, they're communicating via their data terminal with the dispatcher. And while call taking is happening, they're giving pre-arrival instructions, and dispatchers taking that information and they're computer system is telling them which ambulance is closest to be most appropriate to send. So dispatch sends that out, the appropriate personnel, which may be first responders and rescue units, emergency fly cars. And then they can also determine, is this going to be a BLS response or an ALS response? Some systems are both. They have tiered. So they'll have a BLS ambulance respond, and then a rescue would be an ALS responder that would ride in with that BLS ambulance. So, and then they're also going to look at the details, looking at the resources that may be needed and saying, all right, is this going to be okay for ground transport, or perhaps do we need air transport? Most of the time, they're not going to send air transport through a 911 call, unless on the other end of that 911 call is a fire chief or seasoned paramedic or somebody they know. They're like, you need a helicopter on this. So go for that. So once after that point, the ambulance goes, we provide the service, do what we can do, and we transport. Now we arrive at the emergency department. At the emergency department, hospitals have specific specialty care. So in our area, in the Syracuse, the city of Syracuse, the specialized area is Upstate Hospital is a stroke center, also can handle STEMIs, and that's the level 1 trauma center. It's also the burn center, and it's also a pediatric center. Crowd serving, they can handle strokes, they can handle STEMIs, they can handle neonates, so unborn babies if you're having that. High-risk pregnancies, they would go to crowd serving. And then St. Joe's, they have a level 2 NICU there, so they can handle also OB. If the baby's being delivered, they can go there. And they are a very good cardiac hospital. They do not have stroke services. They do have stroke services, but they don't have emergent stroke services. So those emergencies need to go to the stroke facility that's appropriate. More to come on that when we talk about neuro. So specialty care is huge. So identifying the right hospital. And once they receive care at the hospital, they're stabilized, and then they go on for patient rehab. Some of that times that rehab happens at home, but it also might happen in a rehab facility. So part of them being in those facilities is prevention from further episodes of this. When it comes to maybe somebody has fallen and struck their head, or they have multiple falls, that's why they're in the hospital in the first place. Awareness, what do they need? Public education. This is where EMS can help out a lot also. So you're going to, EMS has a thing called quote unquote lift assist, which otherwise known as a patient fell and potentially injured themselves. So it's a fall. So we go there often, we help assess somebody, they're not injured. We're going to assess them up and help them sit back down, make sure they're okay, and say, let's take a look around your place. So we have the prevention awareness. So we're going to look at, do they have the mobility equipment they need? Is their house safe to walk through? Do they have the ability to take care of themselves? Food, that kind of thing. That's where the awareness and education can come in. So on that note, I digress. So let's talk about public access. So the 911 system is a public safety access point. So you're calling a central dispatcher, basically, to the dispatch center. And from that point, they're going to provide emergency dispatch, and they're going to emergency medical dispatch, so they can give you per-arrival instructions until EMS arrives. So tell you how to do CPR, tell you how to deliver a baby, tell you how to help somebody breathe, tell you how to stop bleeding. But you guys won't need this by the time you're all done, because you'll be trained on how to do that. And maybe you could be the call taker sitting and giving EMD. The future is limitless. So the communication systems we have is the caller information. Dispatcher selects appropriate parts of the emergency systems they activate, which we talked about in the round robin there on that one slide. We may be part of a fire department. part of a police department, maybe independent. The independent ones in our area are not-for-profit agencies, a couple municipal agencies, and then private agencies, which are commercial agencies. So talking about that. And then how do we determine what they're due? So we have, as we talk about hierarchy. So we have the medical director. It's usually a physician, is a physician, not usually. He or she authorized the EMTs provide medical care in the field. They're going to determine, have the last say in like, that protocol is good, let's do this. Or you know what, we should also be doing this, and they would oversee that particular care that's being given in the field and support it. So the appropriate care is described in standing orders and protocols. So they have a group of physicians that actually got together and created standing orders and protocols, which we'll talk about what those are in a couple secs here. So medical director, it has an evaluation program. So they maintain quality control. Quality control is for quality improvement. You might hear it referred to as CQI. CQI is continuous quality improvement. Its job is to review charts, review calls, review caregivers, review the quality of care that's given, and then they'll audit that. The goal of this is to see if there's improvement that's needed. And then because we want to assure that the public that we're taking care of, that expects us to, is actually receiving the highest quality of care that they possibly can do. So the goal of this whole thing is to minimize errors. All right. So then we talk about medical direction. Medical direction. There's two types of medical direction. One is offline medical direction. Offline is indirect. So basically those are like, I have the book. This is our treatment protocols that we're going to follow. This is how it's done. This is what is expected to you. You can do these things. You can't stray off that path. This is offline indirect. And these are called standing orders. Protocols, classic example. So then you say, if you have to stray away from your protocol, as long as it falls under something you're trained to do, you may need to talk to DAD or online medical direction. So this is direct. So you're actually talking to them via radio or phone, or and they're going to give you orders over the phone to say, hey, doc, I'd like to do this. A classic example for paramedics for respiratory distress, one of the protocols in our bag of tricks is called magnesium sulfate. Magnesium sulfate is a muscle relaxant that works very well on the bronchial, to help with bronchial dilation, because that bronchospasm, it releases it. So it doesn't fall under the protocol for the emphysema patient or the COPD patient. So, however, it still has an effect with them. So when I have one of those patients, I often, hey doc, I'd like to also give meg sulfate on top of my albuterol treatment and the fluids I'm already giving, because this is their problem. And 9 times out of 10, they usually say, sure, that's what I would do too. So, and then, 10 minutes later, you go to the hospital and they don't believe your story because your patient feeling so much better. So be the proponent, do what you're supposed to do, and utilize the tools you have and the personnel you have. It's a resource. So keep that in mind. Your doctor's not there to hang you up. He's there to help you. So, all right. So EMS falls in this whole integration of the health services, what we do. So we got public health, public safety, healthcare, emergency management. All of this falls in this together, and we work together to make this cohesive system. So there's healthcare that comes into play before we get there. A lot of that is home care, perhaps nursing home care, perhaps a doctor's office. Those lists goes on. And then it starts there, continues with us, then continues at the emergency department after we pick up. So if you think about who are we interacting with, think about which of the health people, the personnel, are we going to interact with? So if we go to a nursing home, we're going to interact with the nurses, the aides, the patient's families, the patient, perhaps a doctor, perhaps a nurse practitioner, perhaps a PA. All of these people are a part of this integrated system that take care of your patient that you're going to take care of. So plethora of information can come to you. Your goal is to continue that care and share information. So when you turn your patient over, that care can continue at the next hospital. So, and then all of this stuff together would not be what it is if we didn't have the research to support it. So the research that we have, it helps determine the shape and impact on the EMS community. Really, research has driven us in such a strong manner that what I was doing in 1996 when I was becoming a paramedic till now are two very different things. Two very different things. So same concept, got to go to point A to point B, but what happens between A and B are two very different things. So this really helps shape that impact on the EMS on the EMS on community, how we do things. So in this impact research on EMS. So this device you're actually seeing in this picture here that she has her finger on is called a Lucas device. This Lucas device is a CPR machine, pretty much. It has a board, goes underneath the patient. This clips onto the board, and then a plunger comes down onto the middle of the chest, just where you put your hands if you were doing compressions on CPR, and you push the play button, it does compressions for you. Does perfect compressions at the perfect rate. So you could do it for 30 to 2, or you could do it continuously. What they have found with the research with this tool is why we use this tool, because of the success rates with it. So it's the impact that we're doing. So, and as we continue down the line, you'll see as you write charts, it has little data points all the way through there. They collect all this data and they utilize it to help the future of the health field. Maybe it's EMS, maybe it's cardiac care, maybe it's stroke care. The whole picture comes in. It doesn't take long to actually just Google a study for EMS, and you'll find all sorts of good studies out there. So Google's your friend as long as you use it correctly. So trust the sites that you go to if you're gonna do fact checking. So, and then you have evidence-based decision making based on the research. So evidence-based meaning they had this research that shows that this evidence is why we do this thing now. So one of the big things is right now, epinephrine there's a conversation of why should we be giving epinephrine for cardiac arrest or should we not be giving epinephrine for cardiac arrest? This falls under that decision making for that because the evidence doesn't necessarily support it. So, all right, moving on, system finance. This goes to it depends on the organization that it works for. So I work for a not-for-profit agency that does about 6,000 calls a year. In this agency, we are very budget driven. We bill. We do not rely on municipal tax money to support our system. However, other systems do. So they have different structures of how that finance works. And then they go into, well, what percentage of each area goes into this financial system. So it depends on the organization. It depends on, so then you take an organization, you take each agency out of it and you look at it, EMS as a whole. You can look at fire as a whole. You can look at nursing homes as a whole. And how does those finances play into the government finance game? Pretty much. So, and here's where we're all falling into place right now in the education systems. So EMS systems instructors are licensed in most states. So I am a newbie. I am just a baby EMT instructor. I'm just starting out. I just received my certifications. I'm very gray, and yes, I'm in my 50s, kind of late in the game to start, but maybe not. I don't know. I enjoy it, but this is where this falls in. I am licensed as a CIC. So this is why I'm teaching right. Um, so continuing down the line, as you move forward, you got to do continuing education. This keeps, as an EMT, we have to keep your knowledge and your skills up to date. So and always refreshing, because a lot of that knowledge and those skills, sometimes that information changes, and that's why this continuing education comes in. So that's why the certifications in most states are set. So like in New York State, we're set for 3 years for certification, unless you have a pandemic called COVID and they keep extending it, which is done. So, but every 3 years you have to recertify, and a recertification during that process, you have to educate yourself in those core topics that are set by the state research, and show proficiency and skills for this reason. Up to date on the changes that have happened, but also making sure that if you haven't put a traction splint on in 3 years, perhaps you should put a traction splint on. Do it. So, all right. And then prevention and public education. This is EMS falls heavily in this area. So this focuses on public health. Why does EMS fall in there? Because EMS is making house calls. We're seeing people in their true environment. So that's where we can really be part of this game. So education, we can help to identify the problem, and then the protective factors, identify risks, preventive strategies, and then when we all put all this information together, we can disseminate it. We can make sure it has an adoption widespread. So emphasis of this program is prevention. We want to prevent the inevitable. We want to keep people that are sick alive, and healthy, and perhaps reduce suffering. So think about, if EMS is making house calls, how can we prevent illness and injury? Think about that. I just kind of mentioned a couple of the things, but really think about that. If you were called to a house, how could you prevent illness and injury? So roles and responsibilities. When we look at roles and responsibilities in EMT, starts in the beginning of the day. We're gonna check our equipment. We're gonna check our vehicle, because a vehicle that doesn't start can't go on a call. The vehicle that starts that doesn't have oxygen can't treat a patient appropriately. So we have to make sure that everything's ready to go every single day. Then ensure safety of yourself, the patient, and the bystanders. A priority when it comes to safety, you and your crew are at the top of the list. Top of the list. You have to, because an injured or a dead rescuer can't rescue anybody. And then you have to operate an emergency vehicle, and you have to do it safely. And then you are the one that has to be the on-scene leader. You're the problem solver. You have to go in and you have to be the leader and solve the problem efficiently and safely. And to do that, you have to evaluate the scene and say, this is what we need and this is what we're going to do. All right. So know your path. Know your path. The fact that this is a funny slide, but there is an actual vehicle in the middle of the water. There's a story behind this, apparently. And I'm sure it's a good one. Actually, this just happened in Utica, New York. I don't think this is the vehicle, though. They had an ambulance stolen from an emergency room or a scene that ended up in the water. So anyway, so our roles and responsibility, what resources do we need? So we look at this situation. How are we going to gain patient access to that? In this hoarding situation, if you have to gain access to it, and your patient's super sick, how are you going to perform the patient assessment? and treat the patient. These are true, realistic problems that we have to look at. So you're going to provide service with a smile. So ask yourself this. Once you become an EMT, you've never taken care of an individual before. You've met them for the first time. Do they know you're a good EMT? Probably not. All they have is the expectation of the exposures they've had to what EMS is supposed to do. And the only exposures they have is from TV usually, 9 times out of 10, unless I've taken an ambulance before. But I notice when I'm nice to people and somebody has taken an ambulance before and I go to the same scene and a couple weeks later, and I love hearing to me, oh, you're so nice. That last ambulance crew that was here wasn't so nice. So now ask that question. How many patients know if you are nice to them? Every patient knows when you are nice to them. Because keep this in mind. If somebody's happy with their service, they're not going to complain about their service. Okay? That doesn't give you permission to mess up. But they don't complain about your service. Makes me feel kind of good when they say, thank you, you guys did a great job. All right. So when you look at professional attributes, say the paramedic on the left was a genius. He was the best paramedic to walk the face of the earth. However, he had no social skills and he dressed like a slob and he looked like a slob and he didn't take care of himself. And the one on the right, he's a mediocre paramedic. He does what he's supposed to do, but you know what? He doesn't have a lot of experience. And he doesn't have the confidence. However, this is how he presents himself. He's very clean uniform, and he looks sharp. In your head, as a layperson, which paramedic would you want? Probably the one on the right? Because that he looks the part. So professional attributes, you have to be the whole picture. You have to take the one on the left and put him in the one on the right's uniform to make him the best paramedic you could ever know, but also look the part. So when it comes to being well groomed, being showered, wearing clean pressed uniform that's not full of wrinkles, tying your boots and shining your boots goes a long way. Think about your elderly family members and who they would respect more when they would walk in that's going to take care of your loved ones. It's notorious for me being a gray-haired paramedic to walk into a scene and not even be the first one in the room, but as soon as I walk in, the attention turns to me and the whole report for the patient starts coming to me, and I point back to my partner and I'm like, please tell them. It's because of the presentation of expectations of when you walk in somewhere. People expect the older, seasoned person to be the one in charge, which is not always the case. But I'm also clean cut. I wear a sharp uniform. That's how we're supposed to look. I try to be the whole package. Some days it can be a challenge. However, I try my best. All right. Clean and neat appearance. So doing that instills confidence. And when we look at this, we have to be more than just appearance. We have to have integrity. We have to have empathy. We have to have the ability to put ourselves in our patient's shoes and understand that they're having a bad day. We have to be self-motivated. This means more than just self-motivated on a scene because I take the bags in because I'm required to. It means self-motivated when you're not on a call and reading educational journals and continuing your knowledge gathering and going out of your way to find out what happened to a patient after you drop them off. You have to be motivated. And then you have to be self-confident. Self-confidence comes with knowledge and experience. Once you start building that self-confidence, it does get a snowball effect. So be careful, because that can actually lead to that quote unquote cockiness, which cockiness can lead to walking into a room and always thinking you're the smartest person in the room. And that can lead to problems. That can lead to self-confidence, can lead to overconfidence. Overconfidence can lead to complacency. Complacency can lead to bad habits. Be very careful. Everybody should be self-confident because of the self-motivation they have to get them to that point. So, in time management, if every time you come off of a call, you go take a nap, you eat a snack, you put your shorts off, how are you utilizing your time? How are you utilizing your time? I like to teach. I'm always preparing something. So then what else we have here? We have communication skills. When you're on scene and it's chaos, you need to take that chaos and you need to make it organized chaos. Organized chaos comes from a solid leader with good communication skills. So that's teamwork and diplomacy. That's right. You don't call people idiots. Sometimes you call them idiots, but you got to know them first. Know your crowd before you start how you display your diplomacy. Then respect the others that are with you, understand their limitations, and utilize their strengths. So respect. And be the patient advocate. If you have somebody with excruciating back pain laying on your stretcher with their knees up, nice and comfortable, you go to the hospital and the charge nurse is really busy and they want to put them in a wheelchair and put them in a waiting room, perhaps it would be time to say to hey, I don't think that's appropriate. They can't sit or stand because of the pain. Sit there and wait with them. Be the advocate. And then careful delivery of care. When I say careful delivery of care, it means don't mess up. We don't mess up because when we're carefully delivering care, we know exactly what we're supposed to do. We know exactly what we're supposed to do because we're sitting here like we are right now, educating ourselves. When it comes to skills, we're practicing skills. All those skills we haven't done in a while, we're going back and doing them again, just so we remember. So think of every patient you take care of. Every patient is entitled to compassion, respect, and the best care that you can deliver. Does that strike home? It does with me. It does with me. Every patient is entitled to compassion, respect, and the best care that you can give them. Because that's what I would want for me, and that's what I would want for my family. So when you're down your pathway in your travels, think about, am I the patient caregiver that I would want taking care of my own family? And then strive to be that one. All right. HIPAA. Have you heard of what HIPAA is? Because you know it's a thing. Been around since 1996. So this is the Health Insurance Portability and Accountability Act. So 1996, this came around and it said, listen, don't talk about patients with anybody else. Nobody else has a right to know that, and it's patient's privacy. The patient's privacy, if you breach that, it potentially is a finable or let me rephrase that again. It's a finable offense, and it could also be civil or criminal when it comes to a breach. So all I'm going to say about HIPAA is if you take care of patients, it's the patient's business and only the people that take care of that patient's business. So please do not talk about and share patient information. It is not good for them. It is not good for you. So here we go. All right. So we're creeping up to the end here. So let's talk about what we just finished here. So let's answer some questions here. Which of the following is an example of care that is provided using standing orders? Read through those. If you said B, you are correct. Quality control in an EMS system is the ultimate responsibility of the who? If you said C, you are correct. Please forgive what's about to happen. I'm going to take this opportunity when I'm done and change this before I get caught with it again. It is C, the medical director, not the EMS administrator. Yes, I know it's wrong. We'll fix it. Upon arriving at the scene of a domestic dispute, you hear yelling and the sound of breaking glass from inside the residence. You should what? If you said C, you are right. Which of the following is not a component of continuous quality improvement, or CQI? If you said D, you are wrong because it's C. See what I did there? So negative feedback. So CQI process is actually should be a positive experience because it's a learning experience. So we identify there's a problem, we fix the problem by educating. So, all right. Which of the following situations would most likely disqualify a person for EMS certification? If you said, are you waiting? Okay, good. B, you are correct. Which of the following should be the EMT's highest priority? If you said C, you are correct. What law allows an EMT to practice? Remember the hint, hint, Bob's your uncle? I said it 3 times. This might come up later. This is the time. What law allows an EMT to practice? Scream into the top of your lungs. In this recording, I'm sure I'll hear you. The public health law, the state law. All right. Which of the following is a professional responsibility of the EMT? If you said C, you are correct. Emergency patient care occurs in progressive phases. What occurs first? What occurs first? Because I really don't know what a phase is. So remember, this was on the chart I showed you with the circular information. That's the incident recognition, because then the next step is the 911 is called. And then they send the appropriate equipment. Which of the following is not a nationally recognized level of EMS care? You said D, you are correct. You contact the hospital via cell phone to obtain orders to administer medication. This is an example of what type of medical direction? If you said A, that is right. Now, I just asked you about 11 questions. Your turn to ask me questions. If you have questions, please ask your instructors, or you can try asking me. Respond to this video, and we'll see what we can do. All right. It's been a glorious day to spend with you. We'll see you the next time.